If you asked most people over the age of 60 what epilepsy looks like, they would describe the same thing: a person falling to the ground, body shaking uncontrollably, limbs rigid and jerking, completely unresponsive. The grand mal seizure, the convulsion, the image that has defined epilepsy in the public imagination for decades. And that image, while accurate for one specific type of seizure, is responsible for the fact that tens of thousands of older adults in the United States are living with undiagnosed epilepsy right now. They are being told they have dementia. They are being told they have TIAs, transient ischemic attacks. They are being told they have panic disorder, inner ear problems, or simply that they are getting older. They have epilepsy, and no one has found it yet because the signs they are showing look nothing like what most people, and too often what most physicians, expect epilepsy to look like in a person over 60. The statistics are stark and largely unknown to the public. According to PMC research, epilepsy is the third most common neurological disorder in adults over 60, following only stroke and dementia. The incidence of epilepsy in people over 80 is 159 per 100,000 per year, the highest rate of any age group across the entire human lifespan. Approximately 24% of all new-onset epilepsy occurs after age 60. A 2024 Medicare data analysis confirmed that the estimated annual incidence of epilepsy in people 65 and older is up to 240 per 100,000, meaning the elderly have a higher rate of developing new epilepsy than any other age group, including children. And according to the AARP reporting on late-onset epilepsy, about 1/3 of people with late-onset epilepsy are misdiagnosed, with some experiencing a delay in diagnosis of up to 2 years. Cleveland Clinic epileptologist Dr. Vineet Punia, cited in that report, confirms that about 1/4 of people with late-onset epilepsy may experience a diagnostic delay of up to 2 years. During those 2 years, every uncontrolled seizure is contributing to cognitive decline, driving mood disorders, and creating fall risks that may result in hip fractures, subdural hematomas, and hospitalization, all of which are preventable with appropriate anti-seizure medication. The reason for this diagnostic delay is not a failure of technology or a lack of available tests. EEG monitoring, brain MRI, and continuous ambulatory EEG recording are all capable of identifying epileptic activity in older adults when they are ordered. The reason for the delay is recognition, the failure to recognize that what an older adult is experiencing is a seizure at all. According to research published in the PMC Journal on Epilepsy in the Elderly, in the VA Cooperative Study on New-Onset Epilepsy in Older Adults, epilepsy was a diagnostic consideration during initial evaluation by primary care physicians in only 73% of patients who were ultimately diagnosed with epilepsy. The most common initial diagnoses listed were blackout spells in 29.3% of cases, syncope in 16.8%, altered mental status in 41.8%, and confusion in 37.5%. The seizure was there, the diagnosis was not. The same patient had the same seizure and received 4 different non-epilepsy diagnoses, each of them plausible, each of them wrong, and each of them delaying the EEG that would have made the correct diagnosis in the first appointment. Studies have shown that 10 to 25% of older adults with an unknown cause of epilepsy develop dementia within 3 to 4 years following their first seizure, making early diagnosis not merely an accuracy matter, but a cognitive preservation matter. Sign number 5 on this list is the one that doctors rarely mention, not because it is uncommon, but because it is so unusual and so unlike what anyone expects from a neurological condition that both patients and physicians routinely dismiss it as a psychiatric symptom, a medication side effect, or simply a strange experience to be ignored. Sign number 1 on this list is the sign that requires calling emergency services immediately. Leave your age in the comments below this video right now and tell us, Have you or someone you know ever experienced any sudden, unexplained episode of confusion or staring that lasted for a minute or two and then passed completely? You may have just described a seizure. And before going through the 15 signs, consider this statistic from the AARP report on late-onset epilepsy. Epilepsy is the third most common neurological condition affecting adults over 50 after stroke and dementia, yet many unknowingly discount these episodes as senior moments, fatigue, or just having an off day. An off day that happens to recur on exactly the same schedule, with exactly the same behavior, lasting exactly the same duration, is not an off day. It is a seizure pattern. And a seizure pattern, in an adult over 60, is treatable. Before listing the 15 signs, it is essential to understand why epilepsy behaves differently in a person over 60 than it does in a younger adult, because the biology of the aging brain changes both the appearance of seizures and the body's recovery from them. The aging brain accumulates decades of changes: small vessel disease from hypertension, atherosclerotic narrowing of the cerebral arteries, areas of subtle scar tissue from minor unrecognized strokes, the atrophy of normal aging that shrinks the brain volume slightly over decades. These structural changes create areas of abnormal electrical activity, zones where neurons have been partially damaged and fire irregularly. When these irregular firings synchronize into a self-sustaining pattern, a seizure begins. In older adults, this process is almost always focal, beginning in a specific, small area of the brain, rather than the generalized, simultaneous whole-brain electrical storm of childhood epilepsy. A science-direct study of 391 patients with first unprovoked seizures found that elderly patients most often had focal seizures with impaired consciousness, occurring in 55.9% of older patients compared to 36.5% of younger patients. Focal seizures are partial. They involve one region of the brain. They produce symptoms that reflect the function of that one region, which is why a seizure beginning in the temporal lobe produces confusion and lip smacking, while a seizure beginning in the occipital lobe produces visual flashes, and a seizure beginning in the frontal lobe produces sudden behavioral changes. The same disease produces wildly different presentations depending on exactly where in the aging brain the abnormal electrical activity originates. The most common specific cause of late-onset epilepsy in adults over 60 is cerebrovascular disease, strokes. According to the Epilepsy Foundation, strokes are the most common cause of seizures in older adults, with approximately 10% of stroke survivors experiencing seizures after the stroke, caused by scar tissue forming on the affected brain areas that sends out abnormal electrical signals. The second most common cause is Alzheimer's disease. People with dementia are 5 to 10 times more likely to develop epilepsy compared to people without dementia. Brain tumors, particularly slow-growing, low-grade tumors, are a third major cause in this age group. Traumatic brain injury from falls is a fourth major cause, particularly relevant because older adults have an increased fall risk and are more vulnerable to subdural hematomas following even minor head trauma. However, according to the PMC research on causes of new-onset epilepsy in the elderly, an underlying etiology can be found in only approximately 50% of older patients, meaning that in half of all cases, the epilepsy develops without any identifiable structural cause. This form, called late-onset unexplained epilepsy, is currently the subject of a long-term study of 600 people over 55 at multiple institutions, investigating the relationship between late-onset unexplained epilepsy and subsequent dementia. The aging brain also recovers more slowly from seizure activity. The period after a seizure, called the post-ictal period, produces confusion, fatigue, and disorientation in people of any age. In older adults, the PMC research on epilepsy in the elderly is explicit. Post-ictal confusion tends to be prolonged in the elderly, lasting for hours and sometimes days to weeks, and may lead to an erroneous diagnosis of dementia. An older adult who has a focal seizure in the afternoon may be confused and difficult to arouse until the following morning, a presentation that, without the witness account of the brief staring episode that preceded the prolonged confusion, looks exactly like acute delirium from a systemic illness or the progressive cognitive decline of Alzheimer's disease. The Rush University Medical Center neurologist and head of the Older Adult Epilepsy Clinic, Rebecca O'Dwyer, MD, has stated directly that uncontrolled seizures are a treatable cause of dementia, and that if epilepsy can be diagnosed and treated earlier, cognitive decline may be slowed. This is the clinical importance of recognizing the 15 signs that follow. Sign number 15. Unexplained falls, particularly falls with no apparent preceding dizziness, no warning, and no memory of the moment of falling. An older adult found on the kitchen floor, fully oriented and coherent within minutes, but with absolutely no memory of what happened in the 2 seconds before they hit the ground. No lightheadedness, no palpitations, no tripping on a rug, just standing at the counter, and then on the floor, and then the ceiling above. Unexplained falls, falls where the cause cannot be identified from the patient's history or from the circumstances of the fall, are one of the most consistent early signs of seizure activity in adults over 60. Falls caused by seizures occur when the focal seizure produces a sudden, brief loss of muscle tone or a momentary disruption in consciousness that removes the automatic postural maintenance that keeps a person upright. There is no warning because the seizure does not produce enough time for the person to perceive what is happening. There is no memory because the seizure disrupts the formation of memory for the seconds surrounding its onset. The floor is hit before the brain has time to register that falling has begun. The person wakes, in effect, already on the ground, with no subjective experience of having fallen. The clinical picture in the emergency department is a senior brought in after a fall, bruised hip, carpet burn on the palm, no memory of the fall, no preceding dizziness, no orthostatic blood pressure drop, no cardiac arrhythmia on the monitor, no positional component. The standard fall workup, orthostatics, cardiac rhythm monitoring, bone density evaluation, medication review, finds nothing. The discharge diagnosis is unexplained fall, possible syncope, follow-up with primary care physician, no EEG is ordered. This is the clinical gap that the Rush University Medical Center epilepsy specialists specifically identify. Blanking out spells and unexplained falls in the absence of lightheadedness, dizziness, shortness of breath, or heart palpitations are the key clinical presentation of seizure-related falls in older adults, distinguishing them from the cardiac or orthostatic falls that primary care physicians more commonly consider. The key clinical clue that separates an epileptic fall from any other type of fall in an older adult, the complete absence of any prodrome, any warning sensation or feeling before the fall, combined with complete amnesia for the moment of impact itself. A fall caused by orthostatic hypotension or cardiac arrhythmia produces at minimum a brief sense of lightheadedness or graying of vision in the seconds before loss of consciousness. A fall caused by a seizure produces nothing. The last memory is standing. The next memory is the floor. Any witness who observed the fall and noted a brief period of staring or unusual behavior in the seconds before the fall is providing information that should immediately trigger neurological evaluation. Sign number 14. Staring spells. Brief episodes of complete unresponsiveness with open eyes, lasting 30 seconds to 2 minutes, followed by confusion. A family member talking to a senior at the dinner table and suddenly noticing that the older adult has stopped responding mid-sentence, eyes open, body still, gaze fixed at a point in the middle distance that seems to be about 3 feet in front of them and 3 feet to the right, and nothing they say penetrates. Calling the name, no response, waving a hand in front of the face, no tracking. The episode lasts perhaps 45 seconds to a minute and a half. Then the older adult blinks, looks slightly confused, says, "Sorry, what were you saying?" and has no memory of the preceding 90 seconds. This is a focal impaired awareness seizure, previously called a complex partial seizure, the most common seizure type in adults over 60, according to the PMC geriatric epilepsy research. According to the Epilepsy Foundation, during a focal impaired awareness seizure, the person loses awareness and stares blankly. Even though their eyes are open and they may make movements that seem to have a purpose, in reality, nobody is home. If the symptoms are subtle, other people may think the person is just daydreaming. The critical distinction from genuine daydreaming. Daydreamers can be recalled with a touch or a moderate sound. A person in a focal, impaired awareness seizure cannot be recalled. They are not inattentive. They are neurologically disconnected from incoming sensory information for the duration of the seizure. The Practical Neurology Review of Epilepsy in the Elderly confirms that staring spells are one of the classic presentations of focal seizure activity in older patients, and that they are frequently mistaken for fluctuations or sundowning in patients with concurrent dementia. Any older adult who is observed having multiple episodes of this blank staring over a period of weeks to months requires neurological evaluation, not reassurance that they are tired or distracted. The specific action for the family member who witnesses a staring spell. Note the exact time on a phone or clock at the moment the staring begins. Note the time when the person comes back to awareness, and observe whether there are any automatisms, any repetitive mouth movements, hand movements, or vocalizations during the episode. Write this down within the next 10 minutes before the details fade. A written record of 3 identical staring episodes, each lasting 60 to 90 seconds, each followed by the same degree of confusion, observed by the same witness, is clinical evidence that will be taken seriously in a neurology consultation. Sign number 13. Repeated confusional episodes. Periods of confusion arriving and resolving suddenly that cannot be explained by sleep, medication, or illness. An older woman waking her husband at 2 a.m. confused about where she is, asking whether they are at the hospital, and by 2:20 a.m., fully oriented, back to normal, with no memory of the preceding 20 minutes. Or an older man at his grandchild's birthday party who suddenly seems not to know whose house he is at, who the children are, or what day it is, for approximately 10 minutes, and then recovers completely and attributes it to the noise and the heat. Or an older woman who, during a phone call with her daughter, stops mid-sentence, begins to sound confused and repetitive, asks the same question 3 times, and then, 2 minutes later, sounds completely normal and says, "Sorry, I think I lost my train of thought." The daughter is unsettled. The older woman remembers nothing unusual. This is the profile of a post-ictal confusional state following a focal seizure, and it is virtually indistinguishable from a brief episode of worsening dementia without knowledge of seizures as a cause. The PMC review of epilepsy in the elderly is explicit that confusional episodes in the elderly should prompt evaluation for complex partial seizures or non-convulsive status epilepticus. Non-convulsive status epilepticus, a prolonged seizure with no convulsive movements, manifesting purely as confusion, altered behavior, or unresponsiveness, occurs more commonly in adults over 60 than in any other age group, and according to the PMC geriatric epilepsy research, the rate of status epilepticus-associated mortality in the elderly is 38%, the highest of any age group, rising to 50% or more in adults over 80. A confusional episode that arrives acutely, lasts between minutes and an hour, and resolves without treatment is not reliably distinguishable from the post-ictal period of a focal seizure without EEG monitoring. The clinical criterion that most reliably distinguishes seizure-related confusion from metabolic or dementia-related confusion is the time course. Seizure-related confusion arrives in seconds to minutes and typically resolves over minutes to an hour. Metabolic confusion from dehydration, electrolyte imbalance, or medication builds over hours to days. Dementia-related confusion worsens gradually over weeks to months. A confusional episode that arrives acutely within minutes and resolves completely within an hour, leaving the person back at their cognitive baseline, is a seizure-related confusional episode until proven otherwise. Any older adult experiencing repeated acute confusional episodes requires neurological evaluation with EEG, not merely reassurance that the confusion is from dehydration or medication. Sign number 12. Unusual nighttime movements. sitting up in bed, repetitive motions, or sounds that the person does not remember in the morning. A wife describing that her husband has started making a grunting sound in the night, a sound that repeats 3 or 4 times, followed by sitting up in bed with eyes open but unresponsive, clasping his hands together repeatedly, then lying back down and apparently returning to sleep. He remembers nothing in the morning. Or a woman describing to her daughter that she is waking up each morning with a bruised knee and no memory of how she got it. Unusual sleep time behaviors, repeated, stereotyped movements that occur at the same point in the night and follow the same pattern each time they are observed, are a classic presentation of frontal lobe epilepsy in older adults, and they are consistently mistaken for parasomnias, REM sleep behavior disorder, periodic limb movement disorder, or night terrors. The Epilepsy Foundation describes a typical focal impaired awareness seizure occurring during sleep as follows. The person makes a grunting sound, as if clearing the throat, then sits up in bed, opens the eyes and stares. The person may clasp their hands together. If asked what they are doing, they do not answer. After a minute or so, they lie down and go back to sleep. The StatPearl's Focal Impaired Awareness Seizure Review confirms that frontal lobe focal impaired awareness seizures are brief, lasting about 30 seconds, occur in clusters multiple times a day or night, are often nocturnally occurring during sleep, and have minimal post-ictal confusion, meaning the person returns to sleep quickly without apparent distress. The clinical distinction from REM sleep behavior disorder, frontal lobe seizures are highly stereotyped, the same behavior in the same sequence each time, whereas REM sleep behavior disorder produces variable, complex, dream-enacting behaviors that change from episode to episode. The partner of someone with nocturnal seizures describes the same movement sequence repeating identically week after week. The partner of someone with REM sleep behavior disorder describes different behaviors on different nights, sometimes kicking, sometimes shouting, sometimes sitting up. The stereotypy is the seizure signature. Any older adult whose bed partner describes identical, stereotyped, repetitive nighttime behaviors, particularly ones the older adult has no memory of, requires neurological evaluation, including ambulatory EEG monitoring during sleep. Sign number 11. Sudden, brief jerking of a limb while fully awake. Myoclonic jerks that are not the normal hypnic jerk of falling asleep. An older adult seated at the kitchen table, reading the newspaper, when suddenly the right arm jerks upward involuntarily, the coffee cup nearly dropping, a movement that lasts perhaps 1 second and then is completely over, with no loss of consciousness, no confusion, no other symptom. Or an older adult watching television and noticing that the right foot has twitched sharply twice in quick succession, for no apparent reason. Or an older adult holding a full glass of water when the right hand gives a sudden involuntary spasm, the water spilling, a movement they describe to their family as, "My hand just jerked on its own." These sudden, brief, involuntary jerks of a limb, occurring while the person is fully awake and alert, not in the transition between wakefulness and sleep, are called myoclonic jerks, and in a senior with no prior history of epilepsy, they are a sign of seizure activity requiring neurological evaluation. The Rush University Medical Center epilepsy specialists specifically distinguish myoclonic jerks from the hypnic jerks that nearly everyone experiences while falling asleep, which are normal and benign, produced by the normal neurological transition from wakefulness to sleep. The hypnic jerk occurs as a person is on the edge of sleep, produces a sense of falling, and involves the entire body simultaneously. Myoclonic jerks occurring in a fully awake senior are categorically different. They are focal, involving one limb or one side of the body. They occur during full wakefulness, and they produce no feeling of falling, no dreamlike sensation, and no whole body involvement. According to the Rush epilepsy team, in a person who is awake, that kind of involuntary spasm is a sign of seizure activity. The Practical Neurology Geriatric Epilepsy Review notes that myoclonic jerks are extremely common in people with dementia, particularly later-stage Alzheimer's disease, making them an especially important sign to recognize in this population, where they may be attributed to the dementia itself rather than recognized as potentially treatable seizure activity occurring alongside the dementia. The clinical consequence of not recognizing myoclonic jerks as seizures in a person with dementia: the seizures go untreated, accelerating cognitive decline, while the underlying cause, epilepsy, remains addressable with the right medication. Any senior experiencing repeated, involuntary limb jerks while fully awake, particularly if the jerks are increasing in frequency or are consistently occurring in the same limb or same hand, warrants neurological evaluation within weeks rather than months. Sign number 10. Missing chunks of time. Vivid memory of one moment and then the next, with a gap in between that others witnessed as a period of blankness. An older adult with a clear memory of standing at the kitchen sink washing a dish, and then a clear memory of standing at the kitchen sink with the dish already dried and in the rack, with no experience of the 3 minutes in between. Or an older adult who attended the entire graduation ceremony but has no memory of watching the graduate cross the stage, only the arrival and the departure. Or an older adult who remembers nothing of a conversation that happened while others were present, not because they were distracted, but because the conversation occurred during a seizure and was simply never encoded into memory at all. Or a woman who drove herself to the supermarket and back and cannot account for 20 minutes of that drive. The journey is completed, the car is parked correctly, the groceries are on the counter, but the middle 20 minutes do not exist in her memory. The family is frightened. The woman is frightened. A dementia evaluation is requested. The dementia evaluation is normal. The correct next step, the one most often not taken, is a 24-hour ambulatory EEG. The Rush University Medical Center neurologist Rebecca O'Dwyer describes a patient who did not remember his granddaughter's wedding, saw photographs of himself at the wedding, knew he attended, but had absolutely no memory of being there. This is the memory gap presentation of focal impaired awareness seizure, and it is one of the most consistently misidentified epilepsy signs in older adults. According to the Rush Epilepsy team, since memory loss and confusion are also common symptoms of dementia, epilepsy may be misdiagnosed as Alzheimer's disease, and the team specifically advises looking for a diagnosis of atypical dementia or when symptoms suggest dementia, but testing shows the person does not have it. In these cases, an EEG can help determine whether epilepsy is the real cause. The AARP reporting on late-onset epilepsy confirms that 1/3 of people with late-onset epilepsy are misdiagnosed, and that 1/4 experience a delay in diagnosis of up to 2 years, delays that carry real consequences because uncontrolled seizures accelerate cognitive decline. An older adult whose family has noticed specific gaps in memory, not the gradual, progressive word-finding difficulty of early dementia, but specific episodes of complete memory loss for a defined period during which the person was present but not responsive, requires EEG evaluation for focal seizure activity. Sign number 9. Temporary one-sided weakness or paralysis. After an episode, Todd's paralysis, that passes completely within hours. An older adult who had an episode of confusion or staring and, when they come back to full awareness, cannot lift the right arm, the arm hanging limply at the side, completely unresponsive to voluntary commands, and who is immediately taken to the emergency department for an acute stroke evaluation. Brain MRI shows no new infarct. The arm recovers completely within 4 hours. This is Todd's paralysis, a temporary post-seizure weakness or paralysis of the part of the body that was involved in the seizure, and it is one of the most reliably misidentified epilepsy signs in older adults because its presentation is identical to that of an acute stroke in the minutes to hours after it begins. According to the NINDS epilepsy resource, Todd's paralysis is a brief period of temporary paralysis occurring in some individuals after a seizure, usually affecting one side of the body, lasting from 30 minutes to 36 hours before going away completely. The paralysis may also affect speech and vision. The 9A's specifically states that Todd's paralysis can resemble a stroke, and that it is important to distinguish the condition from a stroke. The Cleveland Clinic Focal Seizure Resource confirms that Todd's paralysis is a temporary effect, but that it can last several hours, and that describing this to a physician can help with diagnosing and treating seizures. The clinical significance: an older adult who has a brief confusional episode followed by temporary one-sided weakness lasting hours, but whose brain imaging shows no new stroke, may have experienced a seizure followed by Todd's paralysis, not a TIA. The correct next evaluation is EEG and neurology referral, not only vascular workup. Todd's paralysis is not a stroke. It is the brain recovering from a seizure, and the recovery from the paralysis, which happens spontaneously within hours, is itself a diagnostic clue. A stroke-related weakness does not typically resolve completely and spontaneously within 4 hours without treatment. A post-seizure paralysis does. This pattern, weakness appearing after a brief confusional episode improving spontaneously over hours with normal vascular imaging, is Todd's paralysis until proven otherwise and requires EEG monitoring and neurology referral as the next step, not a second course of thrombolysis or anticoagulation for a vascular event that did not occur. Sign number 8. Repeated automatic movements, lip smacking, repetitive chewing, hand picking, or rubbing during a period of unresponsiveness. A family member describing that their older parent during a staring episode makes a rhythmic smacking movement of the lips. Not an involuntary swallow, not a conscious action, but a repetitive, purposeless lip smacking that has a regular rhythm and continues for the entire duration of the staring spell. Or an older adult who, during a confusional episode, repeatedly picks at the fabric of their shirt with the right hand, a picking motion that continues over and over for 60 to 90 seconds while they stare blankly. Or an older adult who makes a repetitive swallowing or chewing motion during the blank periods their family has been observing. These repetitive, involuntary, purposeless movements, called automatisms, are the behavioral hallmark of temporal lobe focal impaired awareness seizures, and they are one of the most clinically reliable signs that a staring episode is a seizure rather than a daydream or a TIA. The Epilepsy Foundation defines automatisms as involuntary movements called automatisms occurring during focal seizures, including rubbing of the hands, lip smacking, and chewing. The Johns Hopkins Medicine Focal Seizure Resource confirms that patients experiencing a complex focal seizure may stare blankly into space or experience automatisms, non-purposeful, repetitive movements such as lip smacking, blinking, grunting, gulping, or shouting. The Stat Pearl's Focal Impaired Awareness Seizure Review notes that oroalimentary automatisms, lip smacking, chewing, or swallowing may occur without loss of consciousness in temporal lobe seizures. The PMC geriatric epilepsy research is important here. In older adults, automatisms are usually not as prominent as in younger patients, and seizures may manifest with a blank stare and impaired consciousness without the accompanying automatisms. This means that the presence of automatisms is a reliable seizure sign when observed, but their absence does not rule out a focal impaired awareness seizure in an older adult. A family member who has observed staring episodes without any lip smacking or hand movements should not conclude the episodes are not seizures. In older adults, the staring alone, complete unresponsiveness for 30 to 90 seconds, warrants seizure evaluation with or without the automatic movements that younger patients more commonly display. Sign number 7. Unexplained episodes of intense fear, anxiety, or dread, arriving without trigger, lasting 1 to 3 minutes, resolving completely. An older adult describing an experience they find difficult to articulate, a wave of intense, sourceless dread that arrives without any identifiable trigger. No frightening thought, no concerning news, nothing in the environment that explains it, and fills the chest and the throat with an overwhelming certainty that something terrible is about to happen. It lasts approximately 2 minutes and then is completely gone, leaving the person slightly shaky and fatigued, but otherwise normal. This happens several times over a period of weeks. The older adult has been treated for anxiety and panic disorder. The medication has not helped. A second opinion results in a referral to a cardiologist who finds no arrhythmia. The episodes continue. This is an aura, a focal aware seizure, arising from the temporal lobe of the brain, specifically from the amygdala, the brain's emotional processing center, and it is being systematically missed because the description of sudden, intense fear sounds exactly like the description of a panic attack. According to the NINS epilepsy resource, focal seizures may cause the person to experience sudden and unexplainable feelings of joy, anger, sadness, or nausea. The Cleveland Clinic Focal Seizure Review specifically lists negative emotions, including fear, anxiety, agitation, and anger, as emotional responses produced by aura seizures. The Kaiser Permanente Epilepsy Resource describes an aura as consisting of, among other things, an unexplained feeling of fear or anxiety. The Psychiatric Journal Review of Focal Impaired Awareness Seizures confirms that some patients experience auras, including emotions such as fear and anxiety. The critical distinguishing feature between a panic attack and a focal seizure aura. Panic attacks typically last at least 10 minutes and often much longer, producing escalating physical symptoms, including tachycardia, shortness of breath, and sweating that build progressively. A focal seizure aura of fear lasts 1 to 3 minutes, resolves abruptly, and is not reliably associated with the physical autonomic escalation of a panic attack. Panic attacks also typically occur in a recognizable context of anxiety or stress. Focal seizure fear auras occur without any preceding context, appearing during ordinary calm activities like reading, watching television, or cooking. The epilepsy action patient accounts document the experience directly: a feeling of dread rising from the tummy, a sense of rising anxiety and nausea, leaving me feeling shaky and like I need to take some deep breaths, feeling absolutely exhausted afterwards. This is not panic disorder. This is a temporal lobe seizure. An older adult experiencing repeated brief episodes of sourceless, intense fear or dread that resolve completely and leave minimal residual symptoms requires neurological evaluation with ambulatory EEG monitoring, not only a psychiatric referral for panic disorder. Sign number 6. Sudden unexplained episodes of intense nausea or a rising sensation in the stomach, the epigastric aura, with no gastrointestinal cause. An older adult describing a very specific sensation, a rising feeling that starts in the stomach or below the sternum and moves upward through the chest toward the throat, like a wave that rises and falls over the course of 20 to 30 seconds, arriving without warning, not related to eating or position, and leaving a feeling of vague unease for several minutes afterward. Or an older adult experiencing repeated brief episodes of sudden, intense nausea, not the nausea of motion sickness or the gradual nausea of gastrointestinal illness, but an acute wave of severe nausea that arrives in seconds, peaks within 30 seconds, and is gone within 2 minutes. These are epigastric auras, focal aware seizures originating in the mesial temporal lobe, and they are among the most commonly misattributed seizure signs in adults over 60, consistently attributed to gastric reflux, gastroparesis, or medication side effects. The PMC Psychiatry Review of Focal Impaired Awareness Seizures confirms that unusual sensory experiences, including nausea and a rising sensation in the stomach, may be experienced as the aura of a temporal lobe focal seizure. The Cleveland Clinic Focal Seizure Resource specifically lists gastric uprising, a rising feeling in the belly, as an autonomic aura symptom of focal seizures. According to research cited in the PMC Psychiatry Review, abdominal aura is associated with temporal lobe seizures with a probability of 74%, meaning that if a patient reports stereotyped, brief episodes of intense rising nausea or abdominal sensation, the probability that this is a temporal lobe seizure aura is extremely high. The epilepsy action patient accounts specifically document the experience, a feeling of dread rising from the tummy, lasting approximately 30 seconds, unaware afterwards, the brain feeling like it needs a rest. This is the subjective experience of an epigastric aura seizure. Any older adult experiencing repeated, brief, identical episodes of intense rising nausea or abdominal sensation with no gastrointestinal cause identified requires EEG evaluation for temporal lobe seizure activity. The specific language to use with the neurologist: I experience a rising sensation in my stomach that lasts approximately 30 seconds, It has happened at least 5 times over the past 2 months. It is always the same sensation. It arrives without warning and without any relation to eating, and it is sometimes followed by a period of mild confusion. That description, particularly the words rising sensation, always the same, 30 seconds, followed by confusion, will be immediately recognizable to a neurologist as a mesial temporal lobe seizure aura. Without that specific language, the same symptom described as stomach problems or feeling queasy sometimes will receive a gastroenterology referral rather than an EEG. Sign number 5. Smelling something that is not there, particularly a burning, rotten, or metallic smell arriving suddenly and fading in under a minute. Doctors rarely mention this sign. An older adult at the kitchen table, with nothing on the stove and no candle lit, suddenly smelling burning meat. A strong, specific smell that is absolutely real to them, that they turn their head to look for the source of, that their family member confirms is not present. Or a woman describing to her physician that she keeps smelling something sweet and rotten, like decaying flowers, for about 30 to 40 seconds, 3 or 4 times over the past month, and that it is always exactly the same smell and it always disappears completely. Or an older adult who tastes a sudden metallic or blood-like taste in the mouth, appearing without any dental problem, any medication change, or any food for 20 seconds and then gone. These olfactory hallucinations and gustatory hallucinations, smells and tastes that arrive suddenly, are very specific, are the same each time, and last under a minute, are seizure auras originating in the mesial temporal lobe or the insular cortex of the brain. And they are the sign that physicians almost never mention when discussing epilepsy because they are so unexpected, so strange, and so easily dismissed as psychiatric symptoms or medication effects. The NINS Epilepsy Resource documents this explicitly. Focal seizures are often associated with auras of nausea, emotions such as déjà vu or fear, or unusual smell or taste. The Cleveland Clinic Focal Seizure Resource lists smelling something that isn't there, usually sudden and unexpected, as a hallucination aura of focal seizures. The Cleveland Clinic also lists taste, also usually sudden and unexpected, often nonspecific, like something metallic, sour, or bitter, as a focal seizure aura. The epilepsy action patient accounts document the experience directly. I start lip smacking and sometimes feel lightheaded and get a strong metallic or blood smell and taste. The Epilepsy Action Resource on Focal Aware Seizures includes hallucinations of smells, tastes, sounds, and visions as characteristic features. The critical reason this sign is almost never mentioned in standard physician consultations. Olfactory hallucinations are far more commonly associated in clinical teaching with psychiatric conditions, particularly schizophrenia, and with the early stages of Parkinson's disease. A physician seeing an older adult who describes smelling things that are not there will most commonly pursue a Parkinson's evaluation or a psychiatric consultation, not an EEG. But the specific quality of a seizure olfactory aura is distinctive. It is brief, under a minute. It is stereotyped, the same smell every time. It arrives without warning and without any preceding context, and it may be followed by a brief period of confusion or blankness. A psychiatric olfactory hallucination is typically more sustained, variable, and integrated into a wider set of perceptual disturbances. An older adult experiencing brief, identical, repeated episodes of a specific smell or taste that they cannot find a source for, particularly if followed by any brief confusion, unusual behavior, or memory gap, requires EEG evaluation for focal seizure activity. This is one of the most treatable presentations of late-onset epilepsy, and it is being systematically missed because no one is asking about the smell. Sign number 4, intense, repeated episodes of déjà vu, specifically episodes that are overwhelming, physically felt, and followed by mild confusion. An older adult describing an experience that is difficult to explain, a feeling that what is happening right now has happened before. Not the mild, passing sense of familiarity that almost everyone experiences occasionally, but an overwhelming, total conviction of prior experience that comes on in a wave, fills the entire sensory field for approximately 30 to 60 seconds, and is physically felt in the chest and the belly, and is then followed by a mild fogginess that lasts several minutes. A woman describing that it happens when she is sitting quietly, not triggered by any particular scene or conversation, that it arrives like a pressure building behind the eyes before spreading through the body, and that during the episode, she is aware that what she is feeling is not a real memory, but is unable to stop the feeling from overwhelming her temporarily. The epilepsy action patient accounts describe it directly. I have focal seizures, which always start with a really powerful sense of déjà vu, which lasts for a couple of minutes, followed by a strange feeling in the head like a wave pulsing through it. Another patient account states, I feel very dazed and confused afterwards, and get a monster headache and feel very tired. This is ictal déjà vu. Déjà vu, produced by a focal seizure arising from the temporal lobe, and it is one of the most specific indicators of temporal lobe epilepsy available. The challenge is that nearly everyone experiences mild déjà vu at some point, and older adults who experience the seizure version consistently underreport it as a medical symptom because they believe it is simply a normal experience that happens to be more intense than usual. The NINS epilepsy resource specifically identifies intense déjà vu or memories as a psychic feeling that may be experienced during focal seizures in which the person remains conscious. The Cleveland Clinic Focal Seizure Review includes déjà vu, a French term for when a new experience somehow feels familiar, as an aura symptom. The Montefiore Einstein Neuroscience Center confirms that the déjà vu of focal seizures can take the form of sudden and unexplainable feelings along with sensations. The corresponding experience, jamais vu, in which familiar environments, faces, or objects feel completely unfamiliar and strange, is equally a focal seizure aura and equally commonly missed. An older adult describing that their own kitchen sometimes suddenly looks completely unfamiliar for 30 seconds, or that their spouse's face sometimes appears for a brief moment as the face of a stranger and then normal recognition returns, may be describing jamais vu ictal auras from a temporal lobe focal seizure. The distinguishing features of seizure déjà vu from normal déjà vu: intensity. Seizure déjà vu is overwhelming, not mild. Duration. Normal déjà vu lasts 2 to 5 seconds. Seizure déjà vu lasts 20 to 60 seconds. Physical quality. Seizure déjà vu is felt in the body, not merely perceived in the mind. And aftermath. Seizure déjà vu is followed by mild fogginess or disorientation that normal déjà vu is not. An older adult who describes déjà vu experiences that are intense, last longer than a few seconds, feel physical, and leave a residual fogginess requires neurological evaluation for temporal lobe focal seizures. Documenting the episodes, when they occur, how long they last, what the experience is like, and what comes after, and sharing this documentation with a neurologist is the step that converts a strange, difficult-to-describe experience into clinical evidence that drives an EEG referral. Sign number 3. Sudden episodes of intense fear or anxiety, combined with a rising stomach sensation and heart pounding, ictal autonomic aura. An older adult suddenly stopping mid-sentence in a conversation, pressing a hand to the chest, describing an overwhelming sensation of their heart pounding, combined with a rising feeling in the stomach and a wave of intense fear or panic, lasting approximately 40 seconds, and then sitting down and collecting themselves before resuming the conversation as though nothing unusual happened. The family has witnessed this 3 times in 2 months. The cardiologist has found no arrhythmia. The gastroenterologist has found no reflux. The psychiatrist has prescribed an anxiolytic that has produced no effect on the episodes. This is an ictal autonomic aura, a focal seizure in which the electrical discharge disrupts the central autonomic network, producing cardiovascular, gastrointestinal, and emotional symptoms simultaneously. The Wikipedia resource on focal seizures confirms that autonomic seizures may manifest as cardiovascular changes, including tachycardia, bradycardia, or ictal asystole, combined with respiratory disturbances and gastrointestinal symptoms, such as nausea and hypersalivation. The clinical significance of this combination, rapid heart rate plus rising stomach sensation, plus sudden fear, arriving together in a 30 to 60-second episode, is that it is neurological in origin, not cardiac, gastric, or psychiatric. The PMC Psychiatry Review of Focal Seizures confirms that unusual sensory experiences, including nausea, a rising sensation in the stomach, and dizziness, may all occur together as features of a focal seizure aura. Ictal asystole, a brief slowing or stopping of the heart during a seizure, has been documented as a cause of unexplained syncope in older adults, meaning that some apparently cardiac fainting episodes in older adults are actually seizure-related. Any older adult experiencing repeated identical episodes combining any 2 or 3 of these features, sudden fear, rising abdominal sensation, heart pounding, in brief bursts of under 1 minute that resolve completely, requires EEG evaluation for autonomic seizure activity rather than continued single-organ investigation. Sign number 2. Sudden visual disturbances, flashing lights, bright zigzag lines, or temporary partial vision loss, arriving without headache and resolving in under 2 minutes. An older adult describing a sudden appearance of bright flashing lights in the right side of both visual fields, not a floater, not a migraine with aura building slowly over 20 minutes, but a sudden onset of flickering bright visual disturbance appearing in seconds, lasting approximately 90 seconds and resolving as abruptly as it arrived. Or an older adult describing seeing a brief period during which the right side of their visual field simply went gray or dark for about 1 minute. Not a floater, not a shadow, a partial field cut that resolved completely. Or an older adult describing bright-colored zigzag lines appearing in the peripheral vision of both eyes simultaneously for about 45 seconds, without any preceding headache, and without any headache developing afterward. These sudden, brief visual disturbances, particularly those affecting one side of the visual field in both eyes simultaneously, arriving abruptly and resolving completely within 2 minutes, are focal seizures originating in the occipital lobe of the brain. The Cleveland Clinic Focal Seizure Resource identifies visual hallucinations as a sensory aura of focal seizures, including seeing bright lights, flashes, or distortions in how objects look, appearing bigger or smaller. The NINS Epilepsy Resource lists visual hallucinations as a possible symptom of neocortical epilepsy originating from the outer layer of the brain. The Wikipedia Focal Seizure Resource confirms that with seizures occurring in the occipital lobe, visual disturbances or hallucinations have been reported. The Cleveland Clinic also notes that aversion of the eyes to the opposite side suggests seizures arising from the occipital region. 2 critical distinctions must be made for occipital lobe seizure visual symptoms. The first distinction is from retinal detachment. Retinal detachment produces a curtain or shadow that comes down over the vision of one eye only, typically persisting and worsening rather than resolving, and requires same-day ophthalmological emergency evaluation. Occipital lobe seizure visual symptoms affect both eyes in the same half of the visual field simultaneously, because the occipital lobes process the visual field from both eyes and resolve completely within minutes. The second distinction is from TIA visual symptoms. TIA, amaurosis fugax, produces complete monocular visual loss, complete loss of vision in one eye, like a gray curtain descending, lasting 5 to 30 minutes. Occipital lobe seizure visual symptoms produce bilateral visual field effects lasting under 2 minutes. TIA visual symptoms require immediate vascular evaluation. Occipital lobe seizure visual symptoms, consistently occurring without headache and resolving completely in under 2 minutes in a stereotyped pattern. The same visual disturbance each time, in the same location of the visual field, require EEG evaluation for focal epilepsy. An older adult describing repeated, brief, identical visual disturbances in the same part of the visual field, lasting under 2 minutes with no preceding headache, requires a neurology referral specifically for occipital lobe seizure evaluation alongside any appropriate ophthalmological and vascular assessment. Sign number 1. A convulsive seizure, body rigidity followed by rhythmic jerking of the limbs, loss of consciousness, possible tongue bite, possible incontinence. Call emergency services immediately. An older adult who has suddenly stiffened, arms and legs extended, body rigid, jaw clenched, fallen if standing, with eyes open and rolled back, followed by rhythmic jerking of the limbs that continues for 60 to 120 seconds, followed by a period of complete unresponsiveness that may last 5 to 20 minutes. This is a generalized tonic-clonic seizure, what most people call a grand mal seizure, and it is a neurological emergency requiring emergency services to be called immediately. In a person over 60 experiencing a first convulsive seizure, the differential diagnosis includes not only epilepsy, but stroke, subdural hematoma, brain tumor, severe metabolic derangement, and cardiac arrhythmia, and the distinction between these requires emergency brain imaging, blood work, and cardiac monitoring that cannot be done at home. According to the PMC research on seizure-related mortality in the elderly, the rate of status epilepticus-associated mortality in the elderly is 38%, the highest of any age group. Status epilepticus is defined as a single seizure lasting more than 5 minutes or a cluster of seizures lasting more than 30 minutes without return to baseline consciousness. Any convulsive seizure in an older adult that continues for more than 5 minutes or that does not lead to full recovery of consciousness within 30 minutes is status epilepticus and requires immediate emergency intervention with intravenous anti-seizure medication. The Rush University Medical Center epilepsy specialists state explicitly, always call emergency services if you notice someone convulsing. The person could have a life-threatening condition such as a stroke or bleeding in the brain and require immediate medical attention. The specific information to give to emergency services, the person's age, any history of prior episodes of staring or confusion in the preceding weeks or months, any known history of stroke or head injury, and the complete timeline of the current convulsion from its beginning. Here is the complete 15-sign framework for late-onset epilepsy in adults over 60. Unexplained falls with no memory of the moment of impact, no preceding dizziness, and no cardiac explanation, requiring neurological evaluation and EEG referral, not only a fall prevention and orthostatic workup. Staring spells lasting 30 seconds to 2 minutes, during which the person is completely unresponsive to voice or touch, followed by brief confusion, requiring EEG evaluation as the primary diagnostic tool. Repeated acute confusional episodes that arrive and resolve completely without medical intervention, particularly overnight or during social gatherings, requiring EEG evaluation and neurological referral rather than reassurance that the confusion is dehydration or tiredness. Stereotyped nighttime behaviors including sitting up in bed, repetitive hand movements, or vocalizations that are not remembered in the morning, requiring ambulatory EEG during sleep, not only a sleep disorder referral. Sudden involuntary jerking of a limb while fully awake, not during the transition to sleep, requiring neurological evaluation within weeks, not months. Missing chunks of time, specific, defined periods during which the person was present and observed by others, but forms no memory of the period, requiring EEG evaluation and differentiation from dementia. Temporary one-sided weakness lasting hours after a confusional episode with no new stroke on imaging, Todd's paralysis, requiring EEG and neurology referral as the next step rather than escalated anticoagulation for a vascular event that did not occur. Repetitive lip smacking, chewing, hand-picking, or rubbing movements during blank staring episodes, automatisms, the behavioral hallmark of focal impaired awareness seizures, requiring same-week neurology referral. Brief episodes of intense, sourceless fear or dread, lasting 1 to 3 minutes and resolving completely, temporal lobe auras, requiring ambulatory EEG evaluation rather than panic disorder medication that will not be effective. Repeated brief episodes of intense rising nausea or abdominal sensation lasting under 2 minutes with no gastrointestinal cause, identified epigastric aura requiring temporal lobe epilepsy evaluation with 60-minute or longer EEG. The sudden onset of a specific smell or taste that is not present in the environment, lasting under 1 minute, stereotyped and identical each time it occurs. Olfactory or gustatory aura, the most commonly missed seizure sign in seniors, requiring EEG evaluation before a psychiatric or Parkinson's referral is made. Intense, physical, prolonged episodes of déjà vu or jamais vu, lasting 20 to 60 seconds and followed by mild fogginess. Ictal déjà vu, requiring temporal lobe evaluation with documented episode log provided to the neurologist. Combined episodes of rapid heartbeat, rising abdominal sensation, and sudden fear arriving together in under 60 seconds. Ictal autonomic aura, requiring EEG evaluation and careful differentiation from cardiac and psychiatric causes before those diagnoses are accepted as final. Sudden visual disturbances, flashing lights or partial field loss in the same half of the visual field in both eyes, arriving in seconds and resolving in under 2 minutes without headache. Occipital lobe, focal seizures, requiring EEG evaluation and differentiation from TIA and retinal pathology. And a convulsive seizure, call emergency services immediately, describe the complete duration and all preceding signs, and ensure the phrase first seizure in a person over 60 reaches the treating neurologist within that admission. The single most important practical action for every senior and every family member who has recognized any of these 15 signs: document the episodes. Write down the date, the time, the duration, exactly what was observed, and what happened in the minutes before and after. A log of 3 staring episodes over 2 months, each identical in duration and behavior, each followed by the same degree of fogginess, each occurring without warning and without any cardiac or orthostatic symptom, is clinical evidence. It is the difference between a neurologist ordering a 24-hour ambulatory EEG on the first visit and a neurologist waiting to see if the episodes recur before ordering any investigation. The Rush University epilepsy specialists specifically advise keeping a log of the circumstances of episodes, including any recent medication changes, and whether the episodes are triggered by meals or exercise, because that documentation can be really helpful in trying to tease things apart. Getting a family member involved helps. People who are having seizures often experience them very differently from what those around them actually see, and having an eyewitness present for the neurology appointment is specifically recommended. The most important message: with appropriate anti-seizure medication, typically lamotrigine or levetiracetam in older adults, both of which are far better tolerated than older agents like carbamazepine or phenytoin in an older person with polypharmacy and reduced kidney and liver clearance. More than half of seniors with new-onset epilepsy achieve complete seizure control. According to the Merck Manual, with medication, 1/3 of people with epilepsy become completely free of seizures, and most become seizure-free shortly after starting treatment. In another third, seizures recur less than half as often as before treatment. The medications exist. The diagnosis is the missing step. The 15 signs on this list exist because the diagnosis consistently arrives too late, after 2 years of blank staring episodes written off as fatigue, after 3 confusional nights attributed to medication, after 4 emergency department visits for falls that generated orthopedic consultations and bone density scans instead of 24-hour EEG monitoring. Uncontrolled seizures are a treatable cause of cognitive decline. Every month of undiagnosed epilepsy in a senior is a month of preventable seizure activity accelerating the very cognitive decline that the seizures are being mistaken for. Bring this list to the next physician appointment. Describe the episodes specifically. Use the clinical language. Staring spell lasting 60 to 90 seconds with complete unresponsiveness. Rising epigastric sensation lasting 30 seconds. Brief, intense déjà vu followed by fogginess. Specific smell or taste appearing for 20 seconds with no source. That language changes the appointment. Watch the next video on screen.